Welcome everyone to the Emedica GP update. This is session 3, April 2025. We're going to look at menopause. So brief introduction for those that haven't met me before. My name is Muhibbur Rahman. I'm a portfolio GP based here in Birmingham and Solihull and a consultant in medical education. I've been writing about GP careers, GP training and MRCGP now for coming up to about 20 years. I sit on the NICE GP reference panel, and our team at Emedica have now trained over 82,000 delegates since 2005 when we first started running courses. Joining me today in the faculty to help answer questions and deal with queries from the core Emedica team, we have Masuda Rahman, Anna Greathead, and Rebecca Bacon. And then in terms of the format, for those that have been to any of the other ones, you know the format. For those that are new, welcome. But essentially in each one of these updates, we focus on one clinical topic to do an update. So today we're going to look at the revised NICE menopause guidelines. And then towards the end, we touch on a demonstration or an example of something that you could use as a practical consulting tip related to the same topic. And we'll finish with a question and answer session right at the end. You can also ask questions throughout. So today, what we're going to look at is the revised NG23. So that was updated November 2024, a significant update to the menopause guideline. So it's interactive. Please use the chat to get involved in the discussion. When I show you a question, you'll have some time to look at it and then use the poll to answer. Okay, but if you've got a question that you'd like myself or the faculty to address, please use the Q&A for that instead. So let's go straight into it. Let's look at, first of all, diagnosing and identifying menopause, but also perimenopause and other conditions that can sometimes present with similar symptoms. Okay, so let's make a start. I'm going to show you a question now. When you see the question, I'll turn my video off so you can focus on it. After about 55 seconds or so, we will launch a poll and then we'll look at the answer and explanations. Here we go. Okay, now, you see this question asks which of the following is the most appropriate next step? A little bit for those of you that are doing MRCGP exams. I know a lot of you are already qualified GPs and we don't need to think about exams anymore and you're happy about that. But for those that have got exams, exam technique is really important. So you can see only one thing. There might be some of these things that you think, oh, I'd like to do that and this and this. But if you ask for the most appropriate, there can only be one right answer. Okay, so only pick one. If you could only do one, and as the next step, having seen this patient, what would be the next thing that you would do if you could only do one? Okay, so the two popular answers are D and E. Okay, D is the most popular. Check FSH levels. Most of you picked that one. Okay, more than 60%. Following that, about a third of you picked check thyroid function, and then the others, it was a small proportion that picked, each one of the others. Okay, so the correct answer is E, check thyroid function. Why is that? Why is it not check FSH level? Again, if we look at the scenario, there's lots of information here. What is the one key that makes us think, okay, actually, we haven't got enough here to make this a worthwhile test to do as the next step? Yeah, well done. So the fact that her periods are still regular, there's no change to her periods, is really important. Look at her age, very young. No change in periods. Now, if you look at some of the symptoms she's got, yes, things like concentrating, being difficult, feeling tired, night sweats, you can sometimes get some of those symptoms around the menopause, but alongside changes in periods, right? Okay, the fact that they're still regular, no change to the periods, then you've got to think what else could cause some of these kinds of symptoms. And that's why checking thyroid function would be a sensible next step, okay, given her age. Now, of course, her mother experienced these same things, but age 50, it's normal to have In fact, 50 is the average age for women to go through the menopause in the UK. Okay. Now let's look at the second one in the set. Okay, great. I'll stop you there. So the split here is, again, between two things. So B and D are the two popular answers. So B was the most popular. The second most popular was D, checking FSH level. So the most popular answer is the correct one. So well done. If you look at this lady, she's 45. Periods are irregular, and this has been going on for 6 months, but they've not stopped, and they've not stopped for a significant amount of time. Okay. Before this, she was someone who was regular, and she's otherwise well. She does have some symptoms. So these fit with vasomotor symptoms, and then we've got some mood symptoms. Okay. And so because she's 45, then we don't need to do FSH levels. We can diagnose based on the clinical history, because she's got typical symptoms that fit with perimenopause, i.e. change in periods, and then having menopausal symptoms like vasomotor symptoms, mood symptoms. Okay, so we look at the guideline for this age range, we don't need to do FSH levels. Okay, let's look at the last one in the set. Okay, so I thought I'd give you a slightly easier one for the last one in the set. Nearly everyone's got this one right, so that's great. So this lady, 52, got both vasomotor symptoms, but also sometimes people will have vaginal symptoms. And this is the key, that the fact she's had no period for 14 months, i.e. it's been more than 12 months, otherwise well, not taking medication, not on any contraception, then that's enough for us to clinically diagnose menopause. We don't need to do any testing, okay? And testing isn't recommended if someone has not had periods for this long with this type of history. So let's look at what the guideline recommends in terms of who we can diagnose without testing, who we might do tests, and what kind of tests, okay? So you can diagnose perimenopause without testing if someone's 45 or more, and you'll sometimes see this in exam settings, that if there's a threshold, they'll set the patient right at that threshold or very close to it to test if you know the guideline. So 45 or more, and they've got vasomotor symptoms, and they've got some changes in menstrual cycle, like periods becoming irregular. Now, it could be that they become less regular or more regular. It can happen either way, okay? So changes in the cycle. And then you can diagnose menopause rather than perimenopause without testing if they've already had a hysterectomy and they've got menopausal symptoms. Because if they've had a hysterectomy, you know, the periods aren't there, the bleeding isn't a symptom that we can rely on. So we just look at having menopausal symptoms. Or they're 45 and over, and they've had no periods at all for 12 months, not irregular periods or light periods. That's not quite enough for them to, but have no periods at all for 12 months, and they're not using any hormonal contraception. That's because if they're still using hormonal contraception, that can cause that amenorrhea, especially, for example, can anyone think of something that someone might be using as a long-term contraception? They've completed their family around this age group, that will often lead to them having no periods at all, and so therefore couldn't rely on. Yeah, the intrauterine systems, the Mirena coil. Okay. Out of interest, as a side point of learning, we often see patients who are on the Mirena coil, have got one in situ. What's the recently updated period that you can use that for? What's the license? It was recently updated. Anyone know? How many years? Great. So most people are aware that it's now 8 years. Used to be 5, with a proviso that if they couldn't get a date for have it removed, it could be used up to 6. Then it was changed to license to be 6. Now it's up to 8 years. Okay. Okay. And then thinking about some of the other things to be aware of, because there might be certain patients or patient groups where you need to tailor how you approach the history taking. But you often see a lower age onset of both perimenopause and menopause in certain patients if they've had family history of there being early menopause or perimenopause, certain ethnic groups, but also some chronic conditions that can lead to changes happening earlier. In terms of testing, what does NICE say? Specifically, they said that you should not test with FSH if they're using hormonal contraception. You shouldn't use AMH, anti-Mullerian hormone, estradiol, inhibin, A or B, ovarian volume, or follicle count. Okay. So let's look at then, what about managing the symptoms? Let's have a look at a question at that. Okay, very interesting. Again, quite commonly we see that it's easy to narrow down some options. You can get rid of some options because they clearly don't fit. The real challenge in an exam setting is usually between the last two choices. And that's what we've seen, is that there's a split between A and D. So recommending lifestyle changes alone and offering combined HRT with estrogen and progesterone. So let's look at the correct answer, and then we'll look at the scenario. So the correct answer is D. This patient would benefit from being offered combined HRT. So why combined? Why can't she have estrogen-only treatment? Because she's got intact uterus. And so if we give estrogen only, then there's an increased risk of breast cancer. And so we need to think about combination. Okay. And why that rather than lifestyle changes alone? If you look at the symptoms that she's got, there are some things that lifestyle changes can help with, but there are some things that lifestyle changes are less likely to be enough for. And where a combined HRT, combined because they've got an intact uterus, is going to be more beneficial. So can you see she's got both vasomotor symptoms and she's got mood swings. And you can see that if her last period was 6 months ago, while we can't diagnose menopause, it's perimenopause at this stage, okay, this lady may not have periods again. And so she may actually be in the menopause. It's just that we can't actually diagnose it yet, okay? We'll again look at things that can help you decide what might be more appropriate, and we'll look at what things lifestyle changes can help, and what lifestyle changes that we might recommend. Okay, we'll look at that later. Let's look at the second one instead. Here we go. Okay, great. This one, most people have got the right answer. The second most popular answer is combined HRT. The correct answer, and the most popular by quite a large amount, is to offer vaginal estrogen. So if you look at this patient, her vasomotor symptoms have pretty much got better. And why might someone have painful intercourse? If they've got vaginal dryness, that also can lead to increased risk of getting UTIs, which is getting recurrent UTIs. Okay, well beyond diagnosing that it is menopause, because she's not had a period for 3 years, and she's otherwise well. And so, you can give something topical here. Vaginal estrogen can be given as a cream. You can also have other methods of delivery, but that may well help to give her both improve the symptoms of things like dryness, which might mean that the intercourse is less painful, reduce the risk of infection, but also just make it more comfortable. Okay. You can also add to that things like lubricants. Okay, so let's look at a question about lifestyle modification, and we'll talk about lifestyle factors and when they might be useful and who they might be useful for. This question is a good example of patient choice and being person-centered in your approach to consulting. Because a patient with these kind of symptoms, so she's got vasomotor symptoms, mood changes, if they've got no risk factors, then there might be a classic candidate that might benefit from HRT. But some patients don't want to take HRT. And remember, there are some risks associated with HRT as well as some benefits, right? And so if they've actively chosen not to have that, then we might recommend some lifestyle modification. And this question is specifically asking, there's two important things in terms of technique. That one is asking about lifestyle modification factors that might help to reduce the vasomotor symptoms, but also about the most effective. So there might be some of these that, more than one might be of some benefit, but which one is there evidence that it's the most effective from the ones listed? Okay, specifically for vasomotor symptoms. And this one, a lot more challenging, big spread. So even the most popular answer, which was A, less than half of you have picked that. And then about a quarter have picked C, and then the rest are about 10% each. So big spread of answers, right? This one's going to surprise a lot of you. So the correct answer is C. Engaging regular aerobic exercise is the most effective from those listed at reducing vasomotor menopausal symptoms in terms of a lifestyle modification. Okay, so let's look at, type into the chat, what other lifestyle factors can help with menopausal symptoms? Then we'll look at, a list of them and look at what things might help in which situation. Okay, so someone said weight loss, smoking cessation, reducing alcohol intake, good sleep hygiene, soy and black cohosh, reducing caffeine. So someone else says reducing alcohol, but reducing caffeine, mindfulness, exercise we already talked about, yeah, diet. So, and someone else has echoed that, regular balanced meals, stress reduction. So things like the mindfulness might help with that. Light clothing, absorbent clothing, especially at night. CBT. So CBT is more an active treatment rather than a non-pharmacological active treatment rather than a lifestyle factor. Lifestyle factors are things that they could do themselves. Hydration, reducing carbs, yoga. Okay, so lots of different things that people have suggested. So let's look at what the guideline says. So exercise, regular aerobic exercise, it can help overall well-being, it can improve mood, it can help with sleep quality in menopausal women, okay? The other thing, think about more beyond just treating the symptoms and treating the patient overall, is that it can also, if someone's doing regular exercise, improve their cardiovascular profile. So it can reduce their cardiovascular risk. And that's something important to think about in postmenopausal women, isn't it? Okay. Getting to a healthy weight, that can definitely help. In terms of reducing caffeine and reducing alcohol, which a few people mentioned. So in a way, some people, those are triggers that can set off some of their symptoms. So it's sort of finding out for a particular patient, it might be that when they have a lot of coffee, they're likely to be more symptomatic. So they can avoid those. Someone else, it might be alcohol. Someone else, it might be smoking. Someone else, it might be spicy food, for example. Okay. So because especially caffeine, alcohol, spicy food, these can sometimes trigger hot flushes, especially. Someone else mentioned about soy and then phytoestrogens. These can sometimes help some women. If we look at the evidence base for it, what it shows is inconsistent in terms of helping some of the vasomotor symptoms. And just changing diet on its own usually doesn't provide significant relief, but as part of other things, it can still be useful. Mindfulness, relaxation, stress reduction, exercise can help with relaxation as well, but these are things that can help with the mood-related symptoms. They don't tend to have that much of an impact on hot flushes or night sweats. And then smoking cessation, this can actually help reduce hot flushes. It is, according to the evidence, the most effective lifestyle modification for symptom relief for the vasomotor symptoms. But again, it has a big impact on reducing cardiovascular risk, which is something really important thinking about sort of, more broadly, our patients' overall risk profile and well-being, okay? Sleep hygiene, that can help because, if you think about one of the symptoms that people often have is tiredness, difficulty concentrating. If you're not sleeping well, that can be made worse. And then part of not sleeping well might be because of having sweat and things like that. So sleeping in a cooler room, having lighter clothing, absorbent clothing, these are things that can help. So really, big takeaway from that is, lifestyle is something that we should definitely consider alongside other things like psychological support. So menopause-specific CBT, for example, medical treatment for some patients, HRT, okay? But it's definitely something that can have an impact. And that if you think beyond the symptoms and the overall risk, then things like getting to a healthy weight, doing regular exercise, cutting back smoking, these are things that can, reducing stress, these are things that can reduce their cardiovascular risk, okay? And then if we look at the HRT itself, if someone's got vasomotor symptoms and they've got a uterus, then combined HRT. If they've had a hysterectomy, so they don't have uterus, then you can use estrogen-only HRT. If they've got premature menopause, you could use HRT, but another option would be the combined oral contraceptive pill, which gives both estrogen and progesterone. And one of the big changes in the revised guidelines is that there's now evidence base that menopause-specific CBT, which previously, CBT was recommended for the mood symptoms, but actually it can be useful for the vasomotor symptoms, the latest evidence shows. And then for mood symptoms, HRT, again, according to that algorithm, but then again, CBT, well known to be something that can be beneficial in mood symptoms. They've got urogenital symptoms, so vaginal dryness, getting recurrent UTIs, and it's not, dipsticks aren't positive, MSUs aren't culturing anything. Then thinking about things like vaginal estrogen, if they're still having symptoms in between, alongside you could use lubricants or moisturizers topically. And if they've got predominantly sexual dysfunction, i.e., it's not that it's painful to have intercourse, they're just not lost interest, low libido, then you've got options of things like tibolone or testosterone. Now, what about if someone's got risk factors? Sometimes we have to think about that in relation to options we've got in relation to HRT. So let's have a look at a question on that. It's a three-way split for this one. So the popular answers are A, reassure and advise on lifestyle changes. And we talked about what lifestyle changes might be useful. D, offer combined HRT but transdermal, so a patch rather than a tablet. And then E was the most popular, offer menopause-specific CBT. So if you look at this patient, the main symptoms she's got are the vasomotor ones, hot flushes and night sweats. Okay. And you can see that this is impacting her sleep, but that's likely to be because of these symptoms, right? And then that then has a knock-on on activities of daily living because she's tired. But the risk factor here is that she's got a history of breast cancer, and that was a hormone-sensitive type of breast cancer. So the correct answer is E, to offer menopause-specific CBT. Remember what we talked about in the last teaching section, that one of the big changes in the new guideline, that the evidence now supports that even for specifically vasomotor symptoms, menopause-specific CBT, there's an evidence base for it. It can be really helpful. Why not combined HRT if it's a patch? Because there's still a risk of breast cancer if they've got a hormone-sensitive breast cancer. Why might someone pick that? Bit of exam technique. Where could we use combined HRT as a patch where maybe oral would not be recommended? What other risk factor? Type into the chat where it might be an option for us to consider. Great. So a couple of options. So one is, if someone's got migraines, then patches are less likely to set that off compared to if they had oral. But the other one is if they've got an increased risk of thromboembolism, where oral might be a contraindication. Transdermal, the risk is reduced significantly. So there is still some risk, but it's not anywhere near as much. And so it can be used. Okay. So someone might have just mixed up the risk, but for breast cancer, it's not recommended. Okay. Because the risk is still significant. And that's really one of the other big things in the new guideline, that it recommends that we discuss the risks and benefits of different options. And there's some very useful decision aids within the guideline itself. So it's worth definitely looking through the actual NICE guideline. And sometimes, I'll have that open in another window and you can use some of the visual aids. I'll show you some of those in a minute. So the big things to discuss is that there's an increased risk of breast cancer and an increased risk of death from those that get breast cancer, a subset, you see, i.e. more people that are on HRT are going to get breast cancer compared to those that aren't. And then of those that get breast cancer, some of those, unfortunately, the breast cancer will be the cause of death. That if you're unsure or if someone's got significant risks, then you could refer for specialist advice. And then we talked about menopause-specific CBT, that, if some of the other options are contraindicated, then that's one of the reasons why you might offer that. Or you have some patients where actually they have no contraindications to HRT. They just don't want to have hormones. They don't like the idea of it. And so they would prefer to have a non-medication based, a non-pharmacological treatment. Again, we can use menopause-specific CBT for these patients. Okay. Right, so let's move on to the next part of the session. We're going to put some of what we've learned into a practical consulting sort of session. Okay. So what I'll do is I'll put up a scenario and then ask for a volunteer to maybe explain this. Okay. And then perhaps I wonder if I could ask maybe Anna or Masuda, if you're happy to be the patient for someone to explain this to. It could be a telephone consult, so you don't need to put your video on. But can I have a volunteer? So this is the scenario. You've got a patient with severe symptoms in relation to menopause. They haven't got risk factors that would be a contraindication to having combined HRT, but they've read in a women's magazine about the risks. There was a story about someone who got breast cancer. It was one of these feature articles about HRT. And so they had a few case studies. There was one lady that had breast cancer, one lady that had endometrial cancer. She's Googled it, she's looked on social media, and as ever, there's a lot of misinformation on social media. So there's also a lot of useful things on social media, but she's now just, some things don't quite match up. There's some things that conflict one with another. And so she's just needing some help. So, what she's asking about is, if she has combined HRT, she wants to know what are the risks. And the task is for someone to explain that in clear, understandable language. So trying to avoid jargon, technical terms, things like that. Okay. So can I have, first of all, volunteer? If you'd like to volunteer, use the raise hand. Okay. And then Anna will be the patient. So Anna, let me enable your mic.
Can you hear me?
Yeah, I can hear you. Great. I think this would be particularly good if you are an ST2 or ST3, and therefore, you're going to have the SCA to sit. It's actually a very typical type of case that you could get. Practice it here, where you haven't got high stakes. It's not an exam. Have a go. Of course, if you're qualified and you want to just have a go, by all means, you're welcome. Okay, so I think Alina was the first one there. So Alina, if you want to enable your mic, if you want to put it on, just tell us your name, where you're logging in from, just so that we can make sure we can hear you.
Hi, I'm logging in from Southampton.
Okay, great.
GPST3 about to give my SCA.
Perfect. Okay, great. So we can hear you, Alina. So I'm going to turn my video off. This is a telephone discussion. So this patient's phoned up and she just wants some advice. Okay. So just imagine you've already taken the history. So you know that she's got no contraindications to combined HRT and she's having significant menopausal symptoms. So she would benefit from it, but her main concern is about this. So I'll start you off where you've already done your introductions. You're already in the middle of the consultation. The patient's going to ask you, can you tell me a bit more about the risks? Okay, so I'll take it from there.
Okay, doctor, I understand what you're saying, but I'm just really concerned about the risks of taking it. Could you try and explain that to me, please?
Hi, Anna. So yes, I can appreciate that you have these symptoms which are quite severe, and you're worried about the risks of taking HRT to manage these. I would like to explain that in a bit more detail, if that's okay.
Okay, thank you.
So, yes, these concerns have been raised in the media, and some of them, while they might be partially correct, others might not be 100% true. And the reason behind it is that, in the past few years, extensive research and studies have been done. One of them being a more popular one called a Million Women Study. I don't know if you've heard about that. Mm, uh,
I think that was mentioned in the article that I read, and there was some women who had taken HRT and they had got breast cancer and a type of womb cancer.
Yep. Yes, that is true. However, I don't know if you know the details of that study. It did state that the risk of having breast cancer and endometrial cancer with that was low
Sorry,
compared to
what did you say? The other word was that, like womb cancer, is it?
womb cancer.
Okay.
Is low is low given the number of women that they investigated, and more so if you use a patch form or a skin patch form of the HRT. Does that make sense?
So if you have it with tablets, there's more risk than if you have it with the patch that you were telling me about.
Absolutely, that's correct.
Okay, and is there still a higher risk?
So there is a risk still, but it's relatively lower when you take it through the transdermal or through the skin patch compared to the oral formulation of HRT.
Okay.
If you have any questions,
Yeah.
yep, sorry.
I've just, I've read all these stories and then I started, and I know you shouldn't Google these things, but it's just got me really confused. And some of the articles say you shouldn't take HRT at all because, so it's just made me very nervous. But as you say, my symptoms are quite severe.
Yes, absolutely. I do appreciate that. And I think what could help is maybe clarifying with that information. I can share some more evidence-based information with you if that helps, maybe face-to-face or via text message. How does that sound?
If you could give me some reliable things to read that I know are, not just off the internet, but are reliable and by doctors and scientists, that might be helpful.
Okay, definitely we can sort that out. Is there any other question you had for me in terms of your concerns?
Well, I certainly think if I can read some good materials, that will help put my mind at rest. And you have explained about the tablets and the patches, so that's helpful.
Okay, absolutely. Absolutely. Thank you.
Thank you very much. A huge thank you for volunteering, Dr. Ahmed. Thank you very much. Okay, great. So let's talk about this. Now, what the guideline recommends is that you have a tailored discussion about risk. Now, some of the risks are really serious, right? So, for example, things like breast cancer, endometrial cancer. Okay, so even if it's a small increase in risk, that's a material risk because the outcome is potentially very serious. Why? Because breast cancer can lead to death. Endometrial cancer can lead to death. You see, we've also got to consider patient factors because there might be some things that if the patient's already got some risks, there might be additional risk added by HRT that for a patient without those non-modifiable risk factors, it will be slightly increased. But if they're already at a higher risk, even a small increase in risk might mean that the balance of risk and benefit is going to weigh differently to a patient who didn't have that. So, things like age, ethnicity, if they've got family history of breast cancer, endometrial cancer, they're already at higher risk. So that might be a patient where you might be a lot more cautious of adding even a small increase in risk through something like HRT. Okay. Then you've also got to think about the form, the delivery, and the duration. So we talked about, for example, things like for migraines, for VTE, that patches sometimes the risk is slightly lower compared to oral. There's still some risk though. Combined versus estrogen only, the impact on risk for, if they've got hysterectomy, not got hysterectomy, breast cancer. The dosage of the different components, the estrogen component, the progesterone component, how long they have it, whether it's continuous or sequential. So if we look at some of the specifics then, so breast cancer risk, the longer they use it, the greater the increase in risk. If they've used it for at least 10 years, then even when they stop, some element of risk persists, even though they've now stopped. Okay. For thromboembolism, the evidence of significant increased risk is only for oral HRT. It's not for patches. And then increased risk of stroke. So if they've got no previous history, it's only if they've combined oral HRT. And the higher the dose of the estrogen component, the longer they're on it, the greater the increase in risk. If they've got a higher age at the start of HRT, that increases the risk. And then there are some differences between different ethnic groups. And then in terms of endometrial cancer, there's a slight increase in risk, but only with sequential combined HRT, okay, for endometrial cancer. For ovarian cancer, there's a slight increase in risk with HRT. And then for dementia, if they're on combined HRT and they're already at 65 years old or older at the time of starting, then there's evidence that that does increase the risk of developing dementia. Now, there are some positives. Remember, we talk about risks and benefits. So there's some decreased risks. So someone on continuous combined HRT, overall, there's a decreased risk of endometrial cancer. So slightly protective. And there is some evidence, although it's limited, that it can reduce the muscle mass loss that we can sometimes see in postmenopausal women. And it can also reduce the risk of fragility fractures. Remember the increased risk of osteoporosis in postmenopausal women. Then there's some things where some of the articles that might say, or sensational things might say, but if we look at the actual evidence, there actually is no evidence of impact. So although there's an increased risk of breast cancer, especially with longer use, and of those that have breast cancer, there's an increased mortality. If we look at all-cause mortality, there is no increase in having HRT. Coronary heart disease, no evidence of impact. Type 2 diabetes, stroke risk if they're having transdermal estrogen only, no evidence of impact. And then if they're having transdermal, even if it's combined, there isn't an evidence of significant impact on risk of thromboembolism. Okay. And then I mentioned that what can be quite useful, when you're talking about some of these things, alongside discussing the risks and benefits, for some patients actually it can be useful to use some of the visual aids. So within the actual NICE guideline, NG23, there's a section where they show these as a visual risk. So if we look at combined HRT and the risk of breast cancer, that between the ages of 50 and 69, i.e. over a 20-year period, out of 1,000 women, 59 who don't ever take HRT were going to get breast cancer. Because remember that, some women are going to get breast cancer anyway, right? If they have combined HRT for at least 5 years from 50 plus, that goes up from 59 to 79, i.e. 20 extra out of 1,000. You see, it's not a huge number when you look at it like that. When you look at it as a relative risk, it looks huge, doesn't it? Because you're going from 59 to 79. That looks like a significant increase, but it's out of 1,000. In total, it's only 20 out of 1,000 extra. That's with 5 years use. So, showing this, there's 1,000 women not on any HRT. This many will have it. There's 1,000 women on HRT, 50 plus. You've got 20 extra women. Okay. Similar visual from that same guideline for women that if we've got people that take combined HRT for 10 years, it goes up from 59 from women that have never had HRT to 92 out of 1,000. Now again, you can see compared to 79 out of 1,000, it is more. And if we look from 59 to 92, it's not quite double, but it sounds like it's almost doubling. But if you look at it as an absolute amount, it's actually not huge, is it? And if you look at it compared to 5 years use, it's added another from 79, 89, 90, it's added another 13 out of 1,000. Not even 1% extra absolute risk, okay? Then if we look at endometrial cancer, out of 1,000 women not on HRT, never taken it, 4 out of 1,000 are going to develop endometrial cancer. So 996 both. If they have continuous combined HRT, doesn't really matter how long. Only 1 out of 1,000, i.e. 3 fewer will develop endometrial cancer. It's actually protective. Doesn't increase the risk of that, actually reduces the risk of that. Okay. So let me summarize, and then we've got some time for questions, and I'll tell you a little bit about some of the other things that we've got coming up. So really, things to consider when we're trying to diagnose perimenopause, menopause, and whether you should test or not test, to think about their age. Are they on medication? Are they on hormonal contraception? What specific symptoms have they got? Have they had a change in periods, for example? Have they stopped periods? How long for? And that you should consider the patient's risk factors, and then the risk factors that we know that are related to HRT and different types of HRT, and that you should discuss both the risks and benefits specific to that patient for different treatment options. So you want to tailor it to your patient. And that, those decision aids and images can be really helpful to help patients get an understanding, especially when we talk about risk. Because if you look at relative risk increase, it sounds like a lot when you say it nearly doubles with 10 years use. Okay. And, like any guideline, things are always changing. So it's important to stay up to date, both for us as doctors seeing patients day to day, that we want to be giving them evidence-based medicine. We want to be up to date, but also especially for those who are sitting exams, that where guidelines have changed recently, this guideline changed, just a few months ago, then it's very common that in the diets of the exam that come shortly after that, they start testing these things. Okay. Now, in terms of Emedica events that are coming up, April is very much AKT month, although we have got an SCA course, but these are all of the events coming up over the next few weeks. So this weekend, we've got our stats half-day course for those sitting in the AKT in April. Or if you want to have an early start for July, that's the morning, it's 4 hours, 9:30 to 1:30. This Saturday afternoon, half-day, covering the key topics from the admin domain. We'll go through 50 questions like this. We went to one question at a time. We did about 6 or 7 questions today. We'll do 50 stats questions, but we'll talk about 60 plus topics, 50 admin questions in the afternoon. Next week, 7th of April, we've got orientation for our July 90-day AKT Pass Guarantee Program. So that Pass Guarantee Program, every day for 90 days, we set you work to do. There's 10 webinars, there's 2 full-day courses, there's a half-day stats, half-day admin, longer clinical grammar webinars, tailored individual revision plan, and a guarantee that if you do all the work and attend everything, you'll pass. Okay, if you don't, you can either get a refund or repeat the program. Next week, Wednesday evening, Thursday evening, we've got, for those sitting the April or July exams, a higher clinical grammar webinar. So these are 3.5 hours each. In each one, we'll go through 50 clinical questions, but they're all topics that were mentioned in recent examiner reports by RCGP examiners. These are things that get tested again and again and again. So across the 2 evenings, we'll cover 100 clinical questions, but over 125 clinical topics. Then on the weekend following, the 12th April, full day AKT 200 question mock grammar. So we do 50 questions in one go, one after the other, in a mock format. And then I go through answer explanations, teaching, there's a handout, then a break, then repeated, then lunch. By the end of the day, we've covered 200 questions, a full mock. Then you get access to a different online full mock after to go through with different questions. Then we've got the 17th April, the first high yield revision webinar for people on our 90-day program. The 90-day program for the July exam, by the way, starts on the 10th of April. And then the 24th April, our MRCGP SCA intensive, full day intensive course. You'll get access to pre-course learning to help understand the exam, how to structure your consultation, how examiners mark, why people fail, how to avoid it, communication and consultation skills. But on the day, we learn through role play. So we'll go through 20 role plays with professional simulators. You get a chance to do a full mock case and get detailed individual feedback, but you also get to watch others get their feedback and learn from that too. Okay. And just a reminder that, this is now our 20th year of helping doctors get into GP training, pass membership, and then navigate GP careers post CCT. And, we've got courses for AKT, for SCA. We've got our CCT Plus course for people about to qualify or qualified and maybe looking at changing, adding something else to their career. So just before we go, please do join the GP Training Support Facebook group. It's the largest such group for people interested in GP training and GP careers. Over 42,000 doctors now. Okay. Please subscribe to our YouTube channel so you can get access to this recording when it's available, but also the previous sessions and things like our SCA Study Club recordings and so on. And then please tell your colleagues if you found it helpful. Those of you that are trainers or program directors, please let your trainees know this is completely free. We run these every couple of months, these updates. If you're qualified and you might be in a WhatsApp group of other GPs and you think, I found this helpful. Sometimes you have to pay a lot of money for CPD. If you can keep up to date and it's engaging, slightly different than just a lecture, we try and put questions, put a case to it so that it's more memorable, hopefully, then, please share, all right? And then if you've got any questions, please let me know. Myself and the faculty will be here for the next 5 minutes to pick up any other questions, okay? For those that haven't got questions, thank you so much. I hope you found it helpful. I do hope to see you at the next one. Like anything in life, prepare and you will succeed.